For years, managing asthma has been, well, a bit of a mess, right? The advice has been all over the place for patients and doctors alike. But 2024 marks a huge reset button. We're talking a total rethink of how we diagnose and treat this condition. So, what's really different? Let's get into it. Okay, so here's our game plan. We're going to start with the why, the huge shift in how we're thinking about treatment. Then we'll dive deep into the new gold standard, these things called ARSA and MART therapy. After that, we'll cover the really critical stuff, like managing an acute attack. Then we'll look at how to even confirm a diagnosis in the first place under these new rules. And we'll wrap up with a super practical guide on how to switch your patients over. All right, first up, the big picture. And when I say big, I mean huge. This isn't just a little update to the old playbook. No, this is a complete overhaul of how we should be approaching asthma care from the ground up. And that brings up a really good question, right? Why are we throwing out an approach that's been around for decades? I mean, what was so fundamentally broken about the old way of doing things? It all boils down to this fundamental difference. The old way? It was all about being reactive. You'd get a little blue reliever inhaler, a SABA, to use when you felt symptoms. And only later, if things got bad, would you add a separate steroid inhaler. The new way? It just flips that script completely. From day one, you get a combination inhaler. So now, every single time you reach for relief, you are also tackling the inflammation that's causing the problem. It's proactive, not reactive. And that gets to the absolute core of the problem. Relying on those SABA-only inhalers, the short-acting beta agonists, it was like just fanning the smoke away from a fire without ever throwing a drop of water on the flames. Sure, it made you feel better for a minute, but it did absolutely nothing to treat the underlying inflammation that was the real fire in your airways. So, if the old way was broken, what's the fix? Well, this brings us to the new standard of care, and it's all built around two key concepts you're going to hear a lot about: AIR and MART. Okay, first up is AIR therapy. That stands for anti-inflammatory reliever. And folks, this is the real game changer. It's a combo inhaler. It's got a low-dose steroid, that's the ICS, and a fast-acting opener called formoterol. And here's the kicker. Patients only take it when they feel symptoms. So, for the very first time, the thing you use for relief is also your anti-inflammatory treatment. They're linked. Now, building on that idea, we have MART therapy, which is short for maintenance and reliever therapy. This is where it gets really clever, really simple. For patients who need more regular treatment, they use the exact same combination inhaler for both their daily maintenance dose and for symptom relief when they need it. One device, two jobs. So much simpler. So this is how it all comes together in the new treatment ladder for anyone 12 and up. Look at this. Everyone starts at step 1 with that as-needed AIR therapy. Simple. If that's not enough, you move to step 2, low-dose MART. Same inhaler, just now you're using it daily for maintenance, plus as needed for relief. From there, you can step up to a moderate dose in step 3. And only after that do we even think about adding other drugs before, calling in a specialist. It's just a much cleaner, inflammation-first approach. Okay, but what about when things go sideways? Let's switch gears and talk about managing an acute asthma attack. This is the emergency plan every single clinician has to know cold. And in that high-stakes situation, the first thing you have to ask is, how bad is this, really? How do you objectively figure out if you're dealing with a moderate attack, a severe one, or something that's truly life-threatening? This table lays out the hard numbers that separate the levels of severity. So you cross that line from moderate to severe when the peak flow, or PEFR, drops below 50%, the person literally can't finish a sentence, and their heart and breathing rates are just skyrocketing. But the real, flashing red lights for a life-threatening attack, that's a peak flow below 33%, oxygen sats dropping under 92%, and maybe the scariest sign of all, a silent chest. That's when there's so little air moving, you can't even hear a wheeze anymore. And listen to this. This is a clinical pearl that could literally save a life. You have a patient who's breathing like crazy, right? You'd expect their CO2 level to be low from all that hyperventilating. But if you run a blood gas and find a normal PCO2, that is a terrifyingly bad sign. It means their muscles are giving out, they're exhausted, and they're about to stop breathing. That situation is immediately classified as life-threatening. Okay, so what do you do right then and there? The immediate moves are crystal clear. You hit them with high-flow oxygen, high-dose SABA like salbutamol, nebulized if it's bad, and oral steroids for everybody.
For the really severe cases, you add in nebulized ipratropium bromide to open the airways another way, and if they're still not turning the corner, IV magnesium sulfate is your next go-to.
But of course, none of this treatment means anything if the diagnosis isn't right to begin with. And that's why confirming the diagnosis is the absolute bedrock of good asthma care. And yeah, there are new rules for this too. And the message from the 2024 guidelines on this is totally unambiguous. We have got to stop just suspecting asthma based on symptoms. From now on, you should not confirm a diagnosis without two things: a classic clinical history and a supporting objective test, period. The guesswork is over. So what are these objective tests? Well, the first-line options are actually pretty simple, and they look directly for inflammation. You've got two choices: either a simple blood test to check the eosinophil count, or you measure something called fractional exhaled nitric oxide, or FeNO. If either of these markers for allergic type inflammation comes back high, that's a huge pointer towards asthma.
Okay, but what if you run those tests and they come back negative, but you're still sitting there thinking, man, this really looks like asthma? What's your next move?
That's when you fall back to the gold standard test: spirometry with bronchodilator reversibility. It's simple. You measure their lung function, give them a puff of a reliever like salbutamol, and then you measure again. If their FEV1, that's how much air they can blow out in 1 second, improves by at least 12% and by at least 200 milliliters, boom, you've confirmed that reversible airway obstruction that is the absolute hallmark of asthma. Okay, last section. Let's get really practical. Because for anyone working in a clinic, the big question is, what do I do with all my patients who are on the old treatments? This is your roadmap for getting them onto the new stuff. The reality is there are millions of patients out there on these, let's call them conventional treatments. The new guidelines know this, and they've actually given us a really clear, really helpful pathway for switching them over.
And here it is. This is your cheat sheet, plain and simple. Got a patient who's just using a blue reliever inhaler? You switch them to as-needed AIR therapy. Someone on a regular low-dose steroid plus a reliever? They move over to low-dose SMART. Same goes for moderate dose. They move to moderate dose SMART. It's a really direct, logical swap from the old treatment to the new, better one. All right, so let's boil this all down to the 4 key takeaways you absolutely need to remember. Number 1, we now treat the inflammation, not just the symptoms. That's the whole point. 2, simplify everything with MART therapy. 1 inhaler for many patients is the new standard. 3, test, don't guess. We need objective proof to make a diagnosis now. And 4, know those red flags. Every clinician needs to be able to spot a life-threatening attack from a mile away. And that leaves us with one last really big question to think about. Now that we're fundamentally shifting our entire approach away from just chasing symptoms and towards managing inflammation from day one, what is that going to mean for the long-term health of millions of asthma patients? I mean, how different will things look in a decade? The answer to that is going to be fascinating to watch, because this isn't just a new guideline. It really is a whole new era in asthma care.